But to your point about cost effectiveness, I think the exciting thing is there are innovations because this is my day job, and excitingly so, there are companies that are driving down the cost of TMS to a fraction. They are brilliant physicians, honorable humans who literally get excited that I get excited about the fact that TMS, synced protocol, accelerated TMS does not need to be $20,000 for a course of treatment. Magnets don't cost that much. So there are people doing amazing work to reimagine even how TMS is delivered. And that is hopefully coming in the next couple years.
A safe haven for innovators to go off the rails.
Welcome back to the Off the Rails podcast, the show about the runaway train that is our healthcare system and the innovators working to derail it. This is your host, Sydney Haytop, and today we're joined by Michelle Bernabe. What's up, Michelle?
Hey, love that tagline. I didn't know that was the podcast tagline.
Yeah.
I'm here to derail things with you.
Off the rails, yeah, because I like to go off the rails here and there. Slightly passionate.
Yeah, a little bit same. I've been off those rails. It's fun. People you meet off the rails, they're good folk.
Better off the rails.
Yeah, it is better off the rails.
Healthcare, well, is better when we take it off the damn rails. But so yeah, I like to start usually with a couple of questions. You're a clinician, so I section it off and I say, for clinicians, where do you practice? What's your specialty or subspecialty?
Cool. So yes, Michelle Bernabe. I'm a nurse trained at Columbia University. Currently working, doing clinical operations development and some growth strategy work with a company called First Tracks. Yeah.
And nurse, what was your specialty?
My specialty was psychiatry, emergency psychiatry, nonetheless. From there, I worked also in addiction and inpatient psychiatry. But my heart lies in comprehensive psychiatric emergency room programs here in New York City, also known as CPAPs.
I want to dig into that.
Yeah.
What's your favorite food?
Oh, wow. I'm Italian, so I love food. I guess pizza, In-N-Out.
Yes.
My body loves soups. There's a saying in Spanish, between love and soup, choose soup.
I really love tortilla soup.
Ooh, yum.
It's like a good hangover killer.
I'm chicken and rice for a hangover cure.
That helps.
Yeah. There's a bar in New York City that serves, maybe you've been to it, chicken noodle soup at midnight.
Oh, no.
That help people going. I don't know. I forget where it is, but I'm sure if you Google bar in New York City, for those listeners, chicken noodle soup, midnight.
So,
yeah.
and do you have any pets?
No. New York City makes it hard.
Amen. I did that.
Yeah.
Okay, cool. Please, tell me what it's like to being an emergency room psychiatric nurse, if I got that right.
Yeah. So I didn't know psychiatric emergency room nurses were a thing. And I'm not sure they are a thing most places, right? Most places, psychiatry patients are in the regular ER, and that can be a horrible experience for someone who's having a panic attack to be in an emergency room. You can imagine how that doesn't go well together. So in New York, they have this wonderful thing called CPAPs, which are comprehensive psychiatric emergency room programs. And to be a CPAP, you have to have a collaborative team of an MD, a nurse, a social worker, and it's this magical healthcare bubble. It's its own. Also, you have to have your own separate space, so it's not a part of the actual. Yeah, and it was a magical healthcare bubble that I grew to love, and I just love the people there. Yeah, it was amazing.
And so it sounds like an integrated team-based approach to super complex and intense care situations, I feel.
Yeah, I can talk about my first time being in a CPAP, right? So I was a student at Columbia University. I had done Camp Ronald McDonald my whole teenage life as a counselor. And I went to Columbia. My mission statement was to be a pediatric oncology nurse. So I wanted to continue that work with kids with cancer. And we all get to spend 1 hour at the psychiatric emergency room at Mount Sinai. And I always thought nothing of it. Okay, it was my hour to go there, whatever. And it's locked doors, so you wouldn't even know you're passing by it, I think. So I go into this locked unit, and it it felt like I was entering like a movie set, right? Like the patient there was like, she's the FBI, she's the FBI. I was just like, what is this? And then, yeah, it was just, I had never seen acute psychiatry. Another patient there that first day, this is graphic, but was literally like war painting themselves with menstrual blood. So it was like a lot of intensity, things I could only seen on TV and film. That's why I've made that first analogy of kind of felt like being in a movie, except this movie is real life and it doesn't stop for people. There is no cut or scene. And yeah, my curiosity was just ignited. What is going on here? Who are these people? Where are they coming from? At least in my rotations in New York City hospitals, the psychiatrists and the CPEP were just so excited to teach me. And they just loved talking about it. And it was just like this unearned mentorship, even in that small hour. And the other thing I love to tell, to circle back to your question about your favorite food, is I happened to be near lunch and they were all sharing food. So this like collaborative team was also like having a meal together in this like small little space. And I was just like, what is this magical healthcare bubble like where people are teaching each other and working together and sharing food and really being thoughtful about the care that is given. There wasn't really this feeling of burnout, which I had experienced in other pockets of the hospital. People weren't mean, which I experienced in other people being the staff of hospitals all around New York City. So we rotated through different hospitals. Yeah. And I was just like, felt this like calling, like I need to figure out how to be here. Like it just was like, they had never taken a student before for longer than an hour. And I was like, I'm going to make you take me on for my internship. And with help of my wonderful little cohort leader, we worked out a scheme to get me to be the first student at that psych ER, and then changed the course of my life.
Amazing. Wow. Yeah, I could only imagine, especially going into a different wing of the hospital. And I don't know, I think having a small pod is in stark contrast to the rest of the hospital setting, just thinking about it.
Totally. Yeah.
Was it like a room or like an area that you walk down a hall and it's, what the hell is this? And then you walk in, it's boom.
No, it's actually
completely different.
Yeah, so right when you enter the walk-in emergency entrance, like you would literally pass there's the
big doors.
Yeah, the big doors.
Yeah.
And then you're walking to be triaged to the emergency room, and then if you look to your left, there's one tiny locked door, like with a tiny little window like the size of a book. And next to that was a public bathroom. The locked door was the psychiatric emergency room. And I think it was 3-bed, 3-bed unit, like 4 chairs.
How many people would cycle in?
Wow. I eventually got them to hire me too, which was a task. They never hired a nurse right out of nursing school. And I worked nights. So they hired me on the night shift, which is a common place for a new nurse to start. And so nights in New York City in the psychiatric emergency room, right? And this was the ambulance catch district for Times Square and Penn Station and Lincoln Center. All to say, it was a pretty full house at times. Like when I first started, there wasn't a limit to the amount of people you could have in that small space. We would have sometimes people standing. There were like 4 waiting chairs, then we'd have them standing. And then it was always, there's this like fun culture in hospitals where you like have to fight to get them to take patients so they can be comfortable. So we would always be fighting with the ER. Of course, they're busy as well, so that's why it's a little bit of a fight. Everyone was good-natured in my experience in the emergency setting, but it was always a fight. Where's the bed? Where can these patients like sit? It was always a creative activity in a New York City hospital.
Wow.
Which is devastating because they're suffering.
What did the course? I'm just curious. What was the experience for a patient that would be, I guess, not really admitted, but that shows up? What does discharge look like? How long does it take? Are they in there with you for a while? Like, what is it, more of a triage area until they calm down? And I feel bad even saying that because I feel like that's not the appropriate way to describe it. But
yeah, I feel like I've always had a very good intuition, but my intuition was really like sharpened sword from working in the psychiatric emergency room, because ideally it would be a 30-minute assessment right? Is this person a danger to themselves or others, secondary to mental illness? And so people can be a danger to themselves or others, not secondary to a mental illness. People can have secondary gains for why they're trying to get into a psychiatric emergency room. Like maybe they're running from their parole officer, or maybe they're on home house and want a sandwich or a place to rest, or maybe it's cold and it's warmer in the hospital. All to say, it's an emergency room. We want to keep people moving. And so it was like this kind of brief assessment. What's really going on? Why are they here? And not to mention the people who sometimes have true mental illness don't want to be hospitalized, right? Because we talk about inpatient hospitalization, that we get into restraints, which is still gold standard, where we tie people to beds, or we can restrain them by locking them into rooms. And not to mention the environment where this is happening, people get agitated, or in psychiatry, it's one of the few places where we can medicate people against their will. So there's court-ordered medications. When it's an emergency, like the emergency room, you don't need consent to medicate, so you can medicate as an emergency against their will. There's a lot of reasons why people who truly need to be in the hospital don't want to be in the hospital, right? I would say justified to an extent. But to the point of what I'm saying, quick assessments, and why is this person here? Are they telling the truth? So I have a really good intuition on who's this person now. It's a superpower I have. Who's this person? Why are they here? And are they telling the truth?
And I'm sure that largely comes down to their ability to trust you also.
Oh, absolutely. Yeah.
Okay. That there's so much distrust in the system, and especially in that context. I can only imagine where it's okay. Is this really an ally? Are they going to screw me over if I tell them the truth? Like,
yeah, totally. And so you use the word mistrust, and there's a thing I like to teach people about. It's called adaptive mistrust. And maybe we spoke about this before, but right, that's when you learn to mistrust things that aren't helpful. And these systems haven't always been helpful. So it's adaptive. It's like a sign of intelligence that they are mistrusting these things. And yeah, as someone who likes to lead with integrity and transparency, if I wasn't always the nurse who was going to sell them on a magical experience they were going to have this hospital. And I think that actually built trust with me. I think part of my magic as a nurse in my career was I was the nurse that would just be like, hey, yeah, you're right to be scared. I would be scared too. This is the best we have. We're going to do our best to help, but we don't always land there. And that's real. Yeah. So I totally, I aligned with the patient. Sometimes to the dislike of managers and psychiatrists, my alignment. But I think at the end of the day, it's the truth. Kind of these systems are still very harmful and scary. Like I wouldn't want to be in them. Yeah. One thing I like to tell people is when I worked in inpatient psychiatry, it wasn't rare to have patients who would say they would prefer prison. They had been in prison and preferred prison to the experience of the inpatient psychiatry. Just to give you an idea of what that experience can be like, how far we have to go to make it more healing and maybe comfortable, safer for people.
That's heartbreaking.
Heartbreaking because they were comparing it to Rikers. We know what that in New York City.
Yeah. Okay. Yeah, I was going to ask about trust, but that just threw me off. Yeah, okay. Quick question, and then we go into the concept of being real and how that it sounds not only help you help patients, but also help them maybe gain some more trust with the overall system, maybe. But before that, do clinicians and is it part of the training at all to have people, administrators, or anyone experience what it is through the whole inpatient admission, psychiatric inpatient admission? Because I have a family history of mental illness and have not myself experienced it directly, but have been close to it. And it is heartbreaking. And I feel like a big piece of the taboo nature of it comes from the fact that people just aren't ever exposed to it. I think that's a big kind of driving factor around anyone who's not really able to be empathetic towards certain people's or certain situations, and just that they've never been exposed to it. And so I guess I'm wondering if there is any bit of exposure, or I guess to what extent is the exposure lifelike for clinicians, or I'm just thinking as administrators, for managing those, I don't call them lines of business because it really dehumanizes the concept, but it is for a lot of these administrators is a line of business. Are they ever exposed to what it is that they're impacting and what it could mean to someone's life having to go through that?
Yeah, no, I don't think it's a formal part. In my experience, I haven't seen it be a formal part of a training that really broke open hearts, right? I'm sure they tour the unit, but when you said that it affected someone close to you, did you visit them on the unit? Have you been to an inpatient psychiatry unit? Yeah.
And that's where the question that's where the question stems from. Is like, you go there and it's a different ballgame, completely different ballgame.
Yeah.
And if you go there in a real world context, again, different ballgame from an empathy standpoint.
Yeah. And when you say different, I'm just trying to understand what you experienced. Did it seem comfortable?
No, I'm saying different ballgame in terms of I sympathize and empathize and frankly want to do something about how fucking scary of a place that.
Okay, I'm just making sure because
stellar walls and the fucking pads, and it's literally like jail, but it's a worse jail because, like you said, they're force feeding you drugs. And
no, totally. Okay, I just want to make sure we were coming from the same place, because there are, I imagine, I've seen these units, nor have I heard anyone been like, wow, it was such a comfortable time and safe time for me in inpatient psychiatry. But I'd like to give room for the imagination that could exist. So maybe was your experience. I like to, make sure. Yeah. But everything you said. Yes.
Yeah. Yeah. Cause I feel part of my perception of behavioral health and mental health and how we treat that in this country, and the fact that it's still very taboo to a large segment of the population, which is absurd to me because it's not. More people experience it than I think everyone realizes, and to some extent something that is not forever. That it's something that you can go through as an episode and not have it be a chronic thing. Obviously for a lot of people that it is, but it can be brought on by life experiences and a lot of different external factors that I feel like people don't understand and really don't allow. They don't give themselves or give others that latitude to be like, okay, I'm going through this and this is what it is. Let's address it. And it's okay that I'm going through it because I'm fucking human, right? And that's the piece of the trust and the humanity. And I feel like that's missing from the outside perspective. And that's where the question stem from, is if you just go in there and realize these are real fucking people and it's just a really sad place for them to be.
Yeah.
Is there a way that we can, and I get in some instances there's not, but is there a way that we can prevent things from getting this bad? And
yeah, totally. So that's been part of what I've been working on since leaving the hospital, right? So for me, there's maybe two buckets. There's making the inpatient experience like a softer, healing place. And then, but having been in some of those systems and trying to use my little nurse voice, that was a battle that didn't seem winnable. So in the meantime, it's how do we, what I'm focusing on with First Tracks, some other projects, is how do we prevent people from needing to be hospitalized? Like treatments that exist that work rapidly for all types of acuity that can be used safely in the community, like transcranial magnetic stimulation and ketamine, Spravato, stellate ganglion blocks, these things.
Wait, can we dig into the stellate ganglion blocks as a treatment modality for behavioral health?
Yeah, PTSD.
Oh, yay, yes.
Yeah, very effective. Very effective. For all of psychiatry, there's going to be we don't have biomarkers, so we don't know who things are effective for yet. That's probably in the next 10 years, but stellate ganglion block can rapidly turn off PTSD for some people.
Yeah, and I have heard of that. And I've heard of, we have a few docs on the network who offer stellate ganglion blocks, and they've talked about how people will come from out of state to treat, PTSD. And with that, and it's something as like a pain management physician that I don't know that everyone, or at least a lot of pain management docs, are so aware of. You tell me, but
yeah. So it's part of the network I'm building is the stellate ganglion block network, and it is a procedure that is more difficult, right? It needs to be ultrasound guided, and it's not like ketamine where you can essentially just stick an IV in, and a nurse could do that. The stellate ganglion block is way more precision based, so it's a more difficult procedure, and you definitely need the training and need the volume in your practice to have done it well repeatedly, because what we know about neural networks is you use it or you lose it. So you want to have someone who has a good volume that's doing it a lot.
And also, I guess when I think about cost and I don't want to say effectiveness, but length of like how long a certain treatment will last is a better word for that. But yes, thank you. Duration of curing, whatever. What do you think is most cost effective? Because I know that both of those treatment modalities, at least in the context of, never mind that, I would say, is it that first one that you said?
TMS, transcranial magnetic stimulation.
The second one.
I said TMS, I said ketamine.
Thank you. Ketamine.
Yeah.
Ketamine is definitely gaining popularity, but I feel like the cost factor is still an issue for some that from an access perspective. And I wonder if, and it seems also that with ketamine, it's more of a higher frequency treatment modality versus stellate ganglion block or TMS, which it sounds like the new version that our friend Owen Weir's talking about can treat and cure depression in a matter of a couple of days, as compared to what I believe like the old version of TMS. I guess he does the same TMS versus the standard TMS. So that's always something that I'd like to explore, is what's the cost effectiveness. And obviously they have varying levels of efficacy for different people. Like you said, the biomarkers will only the biomarkers will truly give us a sense of that. But curious to hear or know what you've seen in the way of duration and cost effectiveness for those three modalities.
Yeah. I think what comes up for me is, cost versus what? Like, how do we measure the cost of suffering when it comes to these treatments? And then who's incentivized to have people well, right? So that's what I do every day at First Tracks, is we're bringing these treatments, all these more advanced treatments. We're trying to build a network, right? What I like to say is if you want ketamine right now, you can call pretty much any ketamine clinic in the nation. I've talked to probably half of them at this point, and they have availability. I've yet to meet a ketamine clinic that does not have availability, a TMS clinic that does not have availability. It's not an access problem in terms of availability. It's an access problem in terms of payment. So then we think about who's incentivized to get people well. And as it's not insurance companies, because their incentives lies with their shareholders. And as the employers actually are incentivized to have a healthy working population. So even if the employer was a quote unquote bad employer that doesn't care about like the moral imperative of getting people well, you can actually prove a cost saving argument to getting people better faster with these treatments, right? Because it reduces absenteeism and presenteeism, and you don't have to worry about firing and rehiring people. And then, especially because these treatments do work on really acute people, on suicidality, on intrusive thoughts, on the depressive part of a bipolar episode, you don't have to worry about people hitting the hospital. So you don't have to worry about that hospital bill. But so that's like the business model side of this. But where I come from as a nurse is what cost can you put on this psychic suffering, which if you have a family member, it is so intense and can be indescribable. It's a different type of pain, not just for the person for the family system.
Yeah, I mean, you feel pain for the person who's going through that and experiencing it. And you do anything to avoid the fucking sterile always.
Yeah.
The physical.
Yeah. And it was completely scandalizing to me to know that there are treatments that exist that get people rapidly better in the community that are evidence-based and cost-effective.
Yeah,
scandalizing.
Do you think, so I guess my initial question around cost was, which one do you think is more like cost effective if you compare them to each other? So I know like the same TMS, super expensive.
Yeah.
Stellate ganglion blocks, not so expensive. And frankly, way less expensive depending on how it's angled. I think that there are a lot of pain management docs that do SGBs in different clinical contexts more frequently. And so the price in those contexts is much lower than if you were to go to someone who knows that, oh, this person's coming for treat a behavioral mental issue. Like, I'm going to hit them with the cost because their alternative is more expensive. So, and that's where that's what I nerd out over is, okay, how can we impact and affect the economics of each of these individual treatments, both from a volume perspective, because with volume, the price goes down, and also just access from an education perspective. Because I think that's the first step of driving volume is helping educate people. Then you educate, then they're like, oh, cool, this is available, and I can get better faster with this. It's the same shit as like a conservative treatment for a musculoskeletal issue versus surgery, curative treatment. Okay, maybe 20 weeks of PT or intensive something could help a little bit elongate your physical capability. But if you're a fucking athlete, you need to get fixed now. And so the way that I see it, and this is going off the rails a little bit, but the way that I see the concept of value-based care is, how do we help connect people with the treatment that they need based on their personal preference at that point in time? Not everyone wants to get cut. Not everyone wants to wait half a year to get better. Not everyone wants to wear a tin thing on their head. Not everyone wants.
Yeah, no, it's true. It's a problem because I want to put a tin thing on everyone's head, but they don't want it.
Exactly. Not everyone wants to be seen as taking ketamine. That still has its own taboo thing. So it's, or not everyone wants to get stabbed in the back or in the neck. That.
Not everyone wants to take oral antidepressants too.
Yeah, I feel like that's the word. That's the
low bar in psychiatry.
For me, that's the whole level. It's like, because the types of treatments that have been available to people to date are those that are more of like treated as like a chronic thing. Obviously, it's a chronic thing, but these treatments seem to have far longer effects that are more acute, but they last longer, and it's almost okay. I could be myself faster.
So it's a light switch. You don't have to do talk therapy. You don't have to talk about any of it, right? Because if it's an inflammation problem and you hit it with TMS or you hit it with ketamine, which both have anti-inflammatory components, the inflammation sequels, right? And your brain is functioning again and you're back. You don't have to talk about it. You don't have to talk about your relationship with your parents. You don't have to think about whatever traumatizing war event you did as a combat soldier. It just switches it off. Yeah, and that's the beauty of these treatments, is they are rapid acting and you don't have to work for it.
And
they rebalance.
People think of, and I say people, I generalize, but even me, like prior to learning about all three of those modalities, were trained, and maybe not even trained. It's just like the public thinks, the public perception of these issues is more of it's completely psycho. I don't know what the right word is, but it's
psychodynamic.
Thank you, exactly. But in reality, it's more like you said, it's a physical thing. So if it's inflammation, then let's treat it as a physical issue, and it can drive, in many instances, more effective results. So let's call it spade. It's not like this one size fits all thing. Let's dig in a little bit more.
Exactly. Yeah, and that's the area or the era of psychiatry we're moving in. So people talk about it like psychiatry 1.0 is the content, right? So that's the therapy. That was, let's talk about this, Freud, blah, blah, blah. Psychiatry 2.0, that's the oral. This is a chemical imbalance in the brain. Let's take serotonin. And psychiatry 3.0 is neurotherapeutics. Like there's a pathology to this in the brain. Let's resync the neurons. Let's quell the inflammation. And I'm sure there's building blocks of all three. We don't have to cancel any of it. But man, you see these neurotherapeutics work, and it's mind-blowing because they're really effective. They're fast-acting, and people have been suffering 10, 20 years. They just stop suffering. Their life is back. They come back. They feel back.
Give me the chills. There's no fucking price. You can't put a price on that at all.
No, but to your point about cost effectiveness, I think the exciting thing is there are innovations. Because this is my day job, and excitingly so, there are companies that are driving down the cost of TMS to a fraction. They are brilliant physicians, honorable humans who literally get excited that I get excited about the fact that TMS, SAINT protocol, accelerated TMS does not need to be $20,000 per course of treatment. Magnets don't cost that much. So there are people doing amazing work to reimagine even how TMS is delivered. And that is hopefully coming in the next couple years. Ketamine, it has no patent, right? Ketamine's very cheap. So that you can drive down the cost of a ketamine IV because ketamine's off patent. Yeah, probably for the ketamine, it's going to be volume to convince people to drive the cost down more. But ketamine's way more affordable than the $20,000 course of accelerated TMS that some people are charging. That being said, if you call around, which all people listening to this should be good consumers of healthcare, you can find accelerated TMS for about $12,000. But again, you want to be thoughtful about who your doctor is. Are they doing measurement-based care? Can they speak to the outcomes of their clinic? But I know fabulous doctors who came out of Stanford brain stimulation lab who are doing it for about $12,500. Yeah. So still, that number is going to be driven down soon. Still, that's not a lot, but.
And is that's Saint, can you just describe that real quick? Is compared to the conventional TMS protocol, Saint is what, like a tenth of the time that?
Yeah. So the standard protocol is about 30 days for TMS, and it's once a day for 30 days. 36 treatments usually. And Saint takes that and compresses it into a week. And the thought is like doing flashcards, right? You're reminding your brain. So it's compressing it into a week. So you get a treatment once a day, once every hour for 10 hours for 5 days. That's one of the protocols. Although, again, because this is my day job, I know that UCLA has a thing called 5x5, where they think you actually don't need to do it 10 times a day. You can do it 5 times a day for 5 days and get the same results. So there is variation to this, but the Stanford protocol is 10 times a day for 10 days. No, 10 times a day, sorry. 10 times a day for 5 days.
Got it. And in addition, for your day job, do you...
Love that day job.
It sounds like a sweet day job. Do you find yourself like navigating or consulting patients to help them navigate?
Yeah, I do both. Yeah, I do both. I'm simultaneously building the network, right? I'm talking to physicians. I'm getting them to believe in this new model of working with employers. And then, like what you said, which is so important, and not many people get it, is psychiatry has a huge gap in PR, obviously, but patient education. So one thing I did not think about is you could bring all these treatments we've just been talking about to patients and then still want to choose oral antidepressants, which aren't as effective and have more side effects because that's the status quo. What they know, that's what's been around, that's what's comfortable. Yeah, I'm currently help educate and navigate patients, and that's my biggest delight because there's no greater joy than when someone just has their mental illness turned off. Like, it's very rewarding when I can lead them to these treatments and they can feel rapid relief. But because of an education gap, but to full circle this conversation, a lot of the adaptive mistrust, right? A lot of the harm that psychiatry has done, again, like my straight shot to trust is being like, this field has been harmful. You have been harmed by SSRIs. Like, it has taken away your libido. You have gained a lot of weight. That's some of the most common side effects.
Those are brutal side effects, by the way.
They're brutal. And I don't think practitioners say, I'm sorry. I'll be the first to say, I'm sorry you had to go through this. But can we collaboratively walk somewhere else? And here's why I think it's going to be more helpful.
Yeah.
Because
That's a missing piece. I think that's
Yeah.
that human touch, and both from the perspective of like navigation and also being able to see yourself in someone else who you
Yeah.
trust, whether it's like a famous person or friend or someone
Oh,
telling
yeah.
you it's okay, like telling you this new thing is okay. I feel like especially people who suffer from mental illness is like that's something that they're looking for is some bit of
Respite.
yeah, thank you. Respect, acknowledgement, acceptance towards
Yeah.
what they're going through and like what they're doing to treat it.
Oh, yeah.
Man,
Totally. It's horrible. It's horrible. The field has to take accountability for its harm. And that's a conversation that has gotten me in trouble, right? I've gotten in trouble for railing against restraints, 4-point restraints, right? The practice of tying people to beds. Because on one hand, one perspective is this is the best we have, right? Which is true, but we can do better. And we need to be talking about how we can do better. We need not to just accept this gold standard of care, which it is in psychiatry. So it can be the best, but we need to say that and also say we need to be dreaming, building, doing something to make this better.
always iterating. Otherwise,
Oh, yes.
dead in the water.
Yeah.
Otherwise, it's like we're accepting what we have is perfect. Fuck no, like absolutely not.
Right. Yeah.
Can you tell us a little bit about the patient with the green eyes?
Yeah. Should I read the poem or should I tell the story? What do you think?
Let's read the poem.
Okay.
And I might want. So we'll take it from there.
We'll take it from there. Okay. So the poem is called Dare I Say God is in the Rails. I'm already going to start crying. I'll probably cry.
So if you might drag me in there with you.
Okay. The sun was setting. It was your turn to pick a song. You typed into YouTube, Ben Howard, Old Pine. So many other nights in that tired and sterile hospital room, we laughed and sang in perfect discord. Then, like a switch of a light, your stare filled my body with sadness. Everything okay, B? I asked. Michelle, I want a job. I want to meet someone to love. You looked out your window to the trucks, which came every evening to offload the hospital morgue. I think I'd be a great boyfriend. I'm strong and kind, and that's what girls are looking for. I watched your sorrow melt into an optimistic smile. Those dark brown eyes, they could see more than any boy should have to. Take your medicine, okay? You don't want to have to keep coming back here. You're 19. You have your whole life ahead of you. You'll get that job. You'll find that girlfriend. Michelle, I'm so lonely out there. The voices are the only friends I have. When I take this medication, I lose them. And without them, I truly have nothing. See, you taught me so much. Okay, C is the initial, since you can't read that. But C, the initial. You taught me so much about the field I was a professional in, making me question the label we slapped on you and the chemicals we forced in you. A tortured mind full of such brilliance. Sunday night, you got off those tracks and walked yourself to the emergency room. See, you lived your life so perfectly. Days later, the sky is dark, and I wake up to an unexpected storm. Hello? I'm sorry, what did you say? I struggled to understand. She tells me you returned to the hospital as you always did, but tears flood my face. I don't understand. I fight a sudden urge to vomit. Michelle, C is dead. She continues, dry and clinical. He came to the emergency room. The team decided he didn't meet admission criteria. They discharged him. And an hour later, he was carried back to the same emergency room, severed in two. I can't feel my body. Michelle, after all these years, his mother finally came to the hospital. Phone goes silent. His mom, she starts crying too. His mom wouldn't stop screaming, banging on the plexiglass windows, inconsolable. You killed my son. You killed my son. I hang up the phone. My hands are trembling, and my mind locks in a loop, repeating the same two words. I'm sorry. I'm sorry that in the year 2017... I'm sorry in the year 2017, we have no system to nourish a life as big as yours. I'm sorry that we thought we knew what was best for you. I'm sorry that we didn't know how to understand you. I'm sorry that after you got off those subway tracks Sunday night, we made the decision that you didn't need help. I'm so sorry there was no place for you. I'm sorry that despite your vulnerability and your bravery, the hospital could only make space for your cold and dismembered body. See, I'm so sorry that so many others, the only thing in this world with enough grace and strength to hold and support your black body, your radiant eyes, your curious mind were those heavy wooden panels and those sharp iron subway rails. I'm so damn sorry. You didn't die fighting your illness. You died fighting ours. See, you lived your life so perfectly, and that's it. Yeah, I haven't read that poem for a while. Sorry, it's tough to get through.
It was beautiful. Thanks for sharing that. I'm like close to a little bit. It sounds like he died fighting the system.
Yeah, so he came to the emergency room from the subway tracks, and then they decided he didn't need help. And he was a kind of a regular patient. It was his first break with schizophrenia, right? So it's an interesting time in a young person's life. And so he came in the hospital room after getting off the subway tracks, and then they said, "You're fine, don't worry about it." And then he just went back to the subway tracks, and then he was brought back to the same emergency room in two pieces, which was devastating to the whole hospital because he was just such a brilliant young boy.
Yes, schizophrenia. It's good to know that there are alternatives and innovative treatments that will hopefully be able to address these far more pervasive than anyone realizes issues that so many people struggle with, and that we're not able to provide adequate fucking treatment.
Yeah. Or have enough room. Like, the main thing is there's no beds in the hospital, right?
And I guess what I'm getting at is we could avoid the hospital altogether.
Yes. Amen. New modalities. Yeah. And even for schizophrenia, there's exciting work. There's a clinical trial going on. I don't know if it's still ongoing at NYU with ultrasound waves with the schizophrenic population. And so with some promising results. So there's these kind of neurotherapeutics that directly impact the brain. There's a lot of hope, even for some of the more difficult to treat pervasive illnesses like schizophrenia.
Good. Thanks for staying on the cutting edge of that.
Yeah.
It gives me hope.
I owe all these people I've met.
We're at about an hour.
Yeah, it's been a pleasure.
Yeah, this has been amazing. Thank you so much for sharing that poem with us. You tell everyone real quick where they can contact you if they have any questions about anything that they've heard, or I think that you'd be open to letting anyone pick your brain about being in this space, because you're awesome.
Totally. One, if you want to read that poem, because I butchered it by crying through it, I have a Substack, Moral Health. You can look that up. To that end, you can email me at michelle@moral.health, because one of my huge other beckoning calls is healthcare would be a lot better if we just had some common values, which we operated off of. So that's what Moral Health is quietly about.
Amen. Yeah, and I would love to dig in further with you about that and maybe have you back on. But
sure,
this is a good one. Thank you so much for taking the time. I'm really grateful to have you on, and I know that everyone listening feels the same.
Oh, thank you. And thank you for creating space for such important conversations. They need to be had. And you know this, but I so adore you and for everything that you're doing for this field. And just read on your Twitter, or I guess it's called X now, that you got the first hospital and network, right? First
hospital in U.S. history.
That's huge.
Yeah, published their full suite of services, inpatient, outpatient, ambulatory, publicly discounted, contracted, publicly for everyone to see, and super excited about that dream come true, for sure.
That's freaking amazing. So I'll say it's an honor to be in conversation with you, and keep up all that you're doing.
Thank you.
That wraps up today's episode of Off the Rails. Remember, you can find us on Spotify, Apple Music, YouTube, and other major podcast channels. Don't forget to subscribe to catch all the content. If you like what you hear, please leave us a review and share it with your friends. Your support means a lot and helps us deliver more authentic takes from real change makers. Follow us on Instagram at GoOffTheRails and follow me on Twitter at Sydney Haytoff. Thanks again for listening. Stay genuine and stay true.